Ms. Tenney?
Thank you, Mr. Chairman. Thank you to the witnesses on this very important issue. End-stage renal disease is one of the most devastating diagnoses a patient can receive. More than 800,000 Americans live with ESRD today. 1,200 in my district are suffering from ESRD. Despite the continuing just 1% of the Medicare population, ESRD patients account for 7% of all Medicare expenditures, more than $50 billion annually, and yet, after more than 50 years, approach to care and treatment for these patients looks remarkably unchanged. This is largely attributable to policy missteps and benefit design failures that need to be addressed. And I just want to, and that's why I think what we're trying to accomplish in this hearing is helpful. On the prevention and awareness side, it seems that too many patients arrive at ESRD because they either didn't know that was coming, their doctors didn't know. Part of the solution is how do we raise awareness at the provider level so doctors know that these patients are driving toward this type of kidney failure in the first place. And I know my uncle suffered from kidney failure for many years and spent many years going to kidney dialysis. But over 42% of Americans over the age of 70 have some form of chronic kidney disease, and 9 in 10 adults with chronic kidney disease don't know they have it. So here we are, a diagnosis issue. And apparently there is a simple way to find out through a blood or urine test. And these are relatively simple and inexpensive and widely available. And I just wanted to maybe, Dr. Taylor, you mentioned this earlier, but maybe if you could just drill down a little bit from a clinical perspective, what do physicians need to do to more effectively integrate the multiple disciplinary care that we need in order so nephrologists, other primary care, and everybody's managing this patient in advance before we know that something like this is happening so that we minimize or at least prolong the chance that ESRD is going to occur?
Congresswoman, thank you for the question. One of the most important things is identifying the underlying risk factors. So diabetes and hypertension are very common, but making sure that primary care physicians and nephrologists are screening appropriately, checking lab tests, checking urine tests to make sure you're identifying the patients that are at highest risk. Unfortunately, and I'll be honest, as a nephrologist, I make a lot more money when someone ends up on dialysis than I do caring for a stage 4 and stage 5 kidney patient. Unfortunately, a patient with chronic kidney disease, stage 4 and stage 5, so advanced kidney disease, may cost Medicare $35,000, maybe $40,000 a year. When they start dialysis, it jumps up to about $90,000 to $95,000 a year. So unfortunately, and I mentioned this earlier, the incentives financially and from a policy perspective have been set up so that as a nephrologist, you make more money and the wheels are greased to put people on dialysis. That's a historic, that's why we have so many patients on in-center dialysis. And so what we've
That's a disheartening thing to hear, actually.
Well, I was asked to testify and to answer honestly.
Yeah, no, I appreciate that. Well, so let me ask you, since when we deal with the TDAPA, the Transitional Drug Add-on Payment Adjustment, would it be better if that were patient-driven? Because now I understand it's facility-driven, so patient-driven based on an individual patient's needs. Is that a way that we could actually help deal with that, the minimizing the cost on that? And is that something that maybe other members on the panel might weigh in on? You can weigh in as well, but maybe Mr. Butler, you want to weigh in too.
I'll be brief. I'll go back to where I really started. Making sure that we prioritize from a policy and financial perspective, going upstream, providing care to patients before they ever need dialysis, and so that you're not talking about TDAPA for ESRD patients. That's where really, as a society and for patients like Ashley, that's where we benefit the most.
Right. And Mr. Butler, I didn't know if you want to say something about the,
No, thank you,
a new approach to the TDAPA program.
That's correct. And right now, it uses this bucket of dollars and gives it by facility, by each dialysis session, rather than when a patient uses the drug. And there's a new product that's a TDAPA product, DefenCath now, that's for a smaller portion of patients, only those with a catheter, that significantly reduces bloodstream infections. Those patients should be able to get the drug, and the dialysis provider should be paid when they use it for that individual patient. We think that will be a significant advantage to allowing patients to access innovation.
Thank you, because I think that there's a bipartisan group of members who would support actually a tax credit up to 50% to leverage this, and to incentivize the development of these cures for rare kidney diseases, especially dealing with this issue right here to save costs on Medicare. But thank you so much to the panel. My time has expired.